Hello viewers, my name is Dr. Rajiv. Welcome to my education channel, YouTube Surgery and Orthopedic Education. Today, there is an online lecture on the clinical assessment of spinal cord injury. In the end, please subscribe to our channel and give us a like if you find the lesson useful. Assessing and treating patients with injuries of the spinal column and spinal cord is challenging. The possibility of a spinal injury must be considered in all trauma patients. The risk of a significant injury to the spine is minimal if the patient has no neurological symptoms, there is a normal neurological examination, there is no neck or back pain, and if the mechanism of injury is unlikely to injure the spine. A spine trauma may cause fracture or subluxation of vertebra or ligamentous disruption. Often bone and ligament injury occur together. This reduces the strength of the spine and may cause instability. A spine trauma may occur with or without neurological injury. Neurological injury from a spine trauma may be either incomplete or complete. If at clinical examination there is some residual motor or sensory neurological function below the level of the lesion, the injury is defined as incomplete. If a complete neurologic deficit persists 24 hours after the injury, there is a very low probability of return of function in the affected region. Neurologic injury from a spine trauma may occur immediately or in a delayed fashion. Immediate injury occurs due to direct damage to the spinal cord or nerve roots at the time of injury. Delayed neurologic injury may occur during transportation, during examination of an improperly immobilized patient, or due to a prolonged hypotensive stroke. The spinal cord extends from the upper border of the atlas vertebra to the lower border of the first lumbar vertebra in adults, whereas in children it extends up to L3 vertebra. The end point of the spinal cord is called conus medullaris. Below this level, it continues as the cauda equina. The lateral spinothalamic tracts transmit pain and temperature sensations. The posterior columns transmit position, vibration, and deep pressure sensation, and the lateral corticospinal tracts subserve motor function. In the spinal cord, the tracts are arranged topographically such that the proximal body function is represented centrally and the distal body function peripherally. The advanced trauma life support principles apply in cases of spinal trauma also. After the ABCDE, that is, airway, breathing, cardiovascular status, disability, exposure, and environmental control has been completed, a thorough neurological and orthopedic history should be obtained and a full physical examination done. The mechanism and velocity of injury should be determined and the presence of spinal pain should be checked. The time of onset and duration of neurological symptoms should also be recorded. Patients typically present after a significant traumatic event such as a motor vehicle accident, fall from a height, or gunshot wound. The knowledge of the mechanism of injury is important in identifying the potential for a spinal injury. Sudden jolt at car or bus accident or while lifting heavy weight in a bent position may cause injury to the spinal ligaments. Fracture and fracture dislocation usually result from severe injuries such as fall from a height or fall of a heavy object on the back. Diving in shallow water may cause dislocation of the cervical vertebrae. Isolated dislocation is not seen in thoracic and lumbar regions. Sudden stoppage of a car due to an accident or sudden braking may result in a seat belt injury, causing injury to the lumbar vertebrae. The most common site of lesion due to an indirect violence is about C6 vertebra. Next to this is L1. The thoracic region is seldom involved after an indirect impact. The spinal cord injury following non-severe or minor impact should raise a suspicion of local pathologies such as degeneration, inflammatory or autoimmune disease, neoplasms, vascular events, or infection. Late onset or gradually evolving paralysis may be due to traumatic intraspinal hemorrhage. Such hemorrhage may occur within the cord itself, known as hematomyelia, or outside the spinal cord but within the spinal canal, then it is known as hematorrhachis. If the patient is testable and cooperative, ask about neurological signs and symptoms. Ask about the presence of new onset neck or back pain, any associated neurological deficit in the hand or lower extremities, such as abnormal sensation like numbness or tingling or motor deficit. Review the patient's past medical history. Osteoporosis is one of the most common pathologies, placing older adults at risk for spinal injury. Other pre-existing conditions may also play a role, such as spinal lytic lesions from a metastatic cancer, rheumatoid arthritis, and ankylosing spondylitis. Seek information about pre-existing neurological deficits. Inquire about any history of prior injuries to the spine and the presence of spinal implants from prior surgeries or interventions. Evaluate all trauma patients according to the principles of advanced trauma life support without considering that whether a spine injury is suspected or confirmed. The spinal level of injury is determined from the assessment of sensory and motor levels of injury. Make no assumptions about the extent of the neurological injury in the presence of a depressed level of consciousness, extremity or pelvic fractures, burns or other injuries such as to the brachial plexus that may affect the results of sensory or motor deficit evaluation. The clinical documentation should be done using the International Standards for Neurological Classification of a Spinal Cord Injury (ISN-CSCI). When a patient is brought in with suspected spine injury, utmost care is taken during the examination of the back and the vertebral column. Any clumsy handling may exacerbate the effects of the injury through additional trauma. At first, the skin of the back is inspected to note the presence of any abrasions or bruising that may indicate the probable site of injury. A swelling along the spinal column may indicate a hematoma, or a prominent spinous process may be due to a fracture dislocation. Now palpate the spinal column with a running finger along the spinous processes and transverse processes. This is called HOLDSWNTH test. An abnormal gap in the line of the spinous processes indicates a tear in the interspinous ligament, which indicates an unstable fracture. Undue prominence of a spinous process indicates a fracture dislocation of the underlying vertebra. In fracture dislocation, the most prominent spinous process is the one below the displaced vertebra. On the other hand, in compression fracture, the most prominent spine is the one above the crushed vertebra. A palpable swelling along the vertebral column usually indicates a hematoma, which will give positive fluctuation test. Movements of the spinal column are not tested at this stage until and unless the stability of the spine is established by radiological tests. Fracture of the coccyx may be detected by a per-rectal examination. Examination of upper limbs. Look for the attitude and disposition of the upper limbs. In cervical spine injuries, the upper limbs assume a characteristic attitude depending on the level of fracture dislocation. If they lie immobile against the trunk and completely paralyzed, the injury is at the C5 level. Any severe lesion above this level will injure the phrenic nerve and may lead to immediate death. In a C6 level injury, the patient lies on the back with the arm abducted and externally rotated and the forearm flexed and supinated due to injury to the fifth cervical nerve. In a C7 level injury, the arm is partially abducted and internally rotated with the forearm flexed and pronated due to the injury to the sixth cervical nerve. In the lesion of the eighth cervical and first dorsal segments, there will be paralysis of the intrinsic muscles of the hand and will lead to a MAIN-EN-GRIFFE deformity. Now test for the sensation and power. The sensation is tested by pinprick, a wisp of cotton, a test tube with cold or hot water, or with the back of a tuning fork. Areas of loss of sensation will be according to the level of the cord lesion. A zone of hyperesthesia lies between the normal and anesthetic skin. The muscle power is tested by asking the patient to use a particular muscle against resistance. Loss of power will also vary according to the level of the cord lesion. Examination of lower limbs. Look for the attitude and disposition of the lower limbs. If both lower limbs become paralyzed, the level of the spinal cord injury is at or above 10th thoracic vertebra. In lesions below L1 vertebra, only the cauda equina will be injured and the lower limb below the knee will be affected by paralysis. The sensation is tested by pinprick, a wisp of cotton, a test tube with cold or hot water, or with back of a tuning fork. The sensory loss will be according to the level of the cord lesion. By running the point of a pin from anesthetic to the normal area, a zone of hyperesthesia will be noted. The sacral roots may be involved in cauda equina lesions, producing anesthesia in the back of the legs and in the saddle area of the perineum with urinary retention. The muscle power in lower limbs is tested by asking the patient to move his ankles and toes against resistance and to raise the legs straight one after the other. If the patient is able to walk normally, it may be assumed that there is no injury to his spinal cord. The term spinal shock refers to a transient extension of reflexes below the level of a spinal cord injury. It starts within minutes following the injury. There is a flaccid paralysis, anesthesia, absent bowel and bladder control, and loss of reflex activity. Initially, all the reflexes may be lost, but they gradually reappear. It is a temporary phenomenon and recovers usually in 24 to 48 hours even in severe injuries. But it may take as long as 6 weeks for the return of reflexes. Complete transection of the cord may be suspected if the reflexes fail to return by this time. Primary causes of a spinal shock are usually a result of high impact direct trauma. Decreased blood flow to the spinal cord can also produce spinal shock. Reflexes first disappear in the segments nearest to the injury, then proceed more distally away from the injured segment. Thus, in high-level cervical cord injuries, sacral reflexes such as bulbocavernous and anal reflex are preserved for a longer period of time. The bulbocavernous reflex returns once the shock has resolved. There is no specific treatment for a spinal shock. General examination. In cases of a spinal injury, a general examination must be performed to exclude any other associated injury to the head, chest, abdomen, pelvis, and the limbs. Investigations. The magnitude and the extent of the trauma and the stability of the spinal column must be ascertained with the help of radiological tests such as X-rays, CT scans, and MRIs. Any pre-existing medical condition should also be excluded or established by appropriate blood tests.